Welcome, everyone. We all know that medicine and critical care, especially, is rapidly evolving. And as critical care doctors, we see our core specialties, colleague specialties, whether it's oncology, surgery, medicine, obstetrics, any specialty you take up in the hospital, they have so many new things going on. And indirectly, we get involved into those new things which are sort of been done by them, their centers of excellence, which are sort of been developed by them. And obviously, as a part and parcel, we also happen to develop and become accustomed to these new processes, procedures, sometimes new therapies. And there is always a space to learn something new. With that in mind, we thought that we need to have a critical care in review for the upcoming year. And the concept is very simple. We are going to have a understanding of what new was done or what new has happened in 2023. And we're also going to reflect on what work has been done in RFH particularly. And then we are going to look forward into the 2024 and see where what new is probably going to happen, where we would like us to be at the end of 2024, so that when we do the next year in review program, what would be the contribution that we will be able to give in this next 1 year. And for which we have included all the different 16 specialities. We've got all the stalwarts who are a part of the program. Most of them, I would say 90% of them are from our hospital. Got one or two people from some other hospitals who are sort of moderators or presenters. And I welcome all of you. And without your contribution, without your knowledge, we would not be able to conduct this kind of a program. Thanks.
Good evening, everyone. And basically, we wanted to start this program with something which is new, which is developing in critical care, and that is transplant critical care. And being RFH being a center of multi-organ transplant, and we have opportunity to see different transplant apart from the routine liver and kidney transplant. We have abundance of cases which is happening for heart and lung transplant. Basically, I would first introduce our panelist. I think Dr. Sandeep Patawar sir is there. Dr. Sandeep Patawar sir is the chair of heart and lung transplant program at KIMS Hospital. And recently, I would like to congratulate him for he has completed 500 heart and lung transplants, and it is amazing, and it's a big milestone in the field of lung transplant for India. And he's pioneer in this field. Uh, Followed by this, I have Dr. Ravi Mohanka. He's also an eminent liver transplant surgeon. He has more than 1,500 liver transplant experience. And his area of interest is how to increase the organ donation and donation after cardiac death. And we have been learning, and he's heading the not only our center, but also entire country to encourage and bring this innovative way of increasing organ donation by introducing DCD. And we have Dr. Bishwarup, who is young and dynamic thoracic surgeon and lung transplant surgeon. He's also a moderator to this session, and he's just come from Auckland with a rich experience. In fact, he has worked in almost all the centers in the world, from Vienna to TGH, Toronto General, and he has a very rich experience in transplants, heart and lung transplant. So, welcome, Dr. Bishwarup. I think Dr. Murray sir is bit stuck somewhere, but I'm sure he will join soon. I just wanted to ask the host that I cannot see these three people right now on my screen. Is there anything I need to do?
We are all there. We are all there.
Sir, you have to change your view.
Yeah. Change your view.
You okay?
And maybe the screen share can stop if you don't want to have the screen share. Everybody will come into a matrix. It will be easy for you to view.
Most of the screen share.
Yeah, and any specific people you want on the top, you can pin them, So when you click on anybody's video, there is an option to pin the three dots, and then you can pin. Then they'll stay at the top.
Yeah. Just a minute. Okay, good. Thank you, Dr. Sandeep. and I can see everyone now. So basically, I would like to start with the thing that Dr. Sandeep, how would you like to quickly summarize your journey of heart and lung transplant from the time you begin your first lung transplant and now till date? What are the changes you have seen in the field of critical care when you see your lung transplant patient, especially what type of ICU you would like to have when you shift your patients post-operatively or perioperatively to the critical care?
Yeah, thank you so much, Ketan. Dr. Pandit, thank you so much. Ravi, it's a pleasure to be on the same panel with you. Bishwa, good afternoon, and to everyone there on this webinar. I think it's an amazing experience to be here, and also the fact that we can encourage many youngsters to probably consider a career in organ transplantation. I think this is a step in the right direction. So, coming quickly to your question, Ketan, I think when we started back in 2011 and 12, organ transplantation was a novelty in India. When I mean organ transplantation, I mean heart and lung transplantation. There were probably a couple of centers with a little bit of scattered experience in Delhi and in Chennai. One of the prime limitations continued to be the fact that organ donation was probably in its early days. There hadn't been any governmental, kind of focused federal insight into probably considering organ donation or deceased organ donation to form the bedrock of therapies for patients with end-stage organ disease. However, at around the same time, there was an explosion in the field of liver transplantation. There's some remarkable work done by some pioneers, and I think I would request Ravi to elaborate a little more on that. And I think that was probably the moment that changed everything for heart and lung transplants, because there were many centers that now considered, moving in the direction of deceased organ liver transplantation. And I think there was also an opportunity for heart and lung programs to piggyback on the fact that liver transplantation was beginning to take off. Unfortunately, most of it happened in cities like Chennai and Bombay, probably to some extent in Bangalore. So it was Western India and Southern India that led the way forward. Probably Ravi can tell us a little more about it. I think we were in the slipstream, if we use the term from Formula One racing, we were in the slipstream. We saw an opportunity, and that's when we started. I think the good part for us was that in those early days, since there were no takers for hearts and lungs, there were a few recipients who probably would turn up with end-stage heart and lung disease, and they knew that this was the only option. These were also days when the previous Chief Minister of Tamil Nadu, Mrs. Jayalalitha, was very unwell, and I think she'd passed away. So ECMO had just come into the what would I say, into the ambit of the public's understanding. So there were opportunities that presented themselves. I would consider that serendipity. And probably we were people who were there at that right moment. We took advantage of it. However, having said that, I think in the intensive care, what was very important was we saw the evolution of an intensivist who collaborated very closely with pulmonologists. So we saw a lot of exchange of information and cross-fertilization of ideas. And I think that helped us tremendously in developing state-of-the-art ICUs, which have now evolved to the stage that they are right now. I hope that answers some of your questions.
Fantastic, sir. And I think that's cross in linkage is important. Dr. Ravi, what do you want to say from your experience of 1500 liver transplant? So, what do you
Yeah.
think?
So, when we started doing liver transplants in India, this was, I started in 2003, but the first one was done in 1998. At that time, we had a lot of difficulty in keeping these patients stable and actually take them to transplant. Almost all ALF patients, acute liver failure patients, would die without a transplant. There were no acute on chronic liver patients who would ever survive. The only patients who could undergo a transplant are the stable cirrhotics and who got a cadaveric liver. And that was very rare. Over all these years, what has happened is that now we have such excellent care of acute liver failure patients that a lot of them we are able to salvage even without transplant, especially the ones with hepatitis A, hepatitis E, and some drug-induced liver injuries. ACLF patients who again were a no-no for transplant in the past, they are now, it's possible and often possible for them to go to a transplant with even renal failure and sometimes being on the ventilator also and sometimes being on the dialysis. So this was never a possibility in the past. As far as cadaveric donors are concerned, in the past we saw that they were really poorly managed, and we ended up getting very poor quality organs. Now that has changed, and this has changed with the efforts of the society, critical care society also. And now donors are much better managed. The protocols are established. There is a way to call somebody and ask what to do in a certain situation. Post-operatively also, in the past we never could handle severe infections. Now it's not so difficult. We are able to take on much more difficult cases. In fact, there is a patient who we transplanted about a month and a half ago with severe HPS. Now she is recovering on an ECMO, which is all, used to be just theory in the past. So I think that's where we have made a lot of progress in all these areas with the critical care in liver transplant. And my hope and wish is that we should be able to work together to bring TCD to India.
So, Dr. Pandit, as both the surgeons have acknowledged our contribution to their progress, so you being part of the first heart transplant in the Maharashtra state, and till that you have been looking after so many heart and lung transplant and other organ transplant. Few quick points which you think has changed is something new. The audience which have joined us, what should they do at their centers if they are running a transplant program? Just
There
initial.
are, Ketan, I think very well put up by Dr. Atawar as well as Dr. Mohanka. It's a symbiotic relationship. The transplant as well as intensivists, we both have grown together. And obviously, better organs have come, better processes to preserve organ integrity is now being practiced. But let me just go back to the basic. Why are we here as intensivists? There are two roles. One is the role as a transplant intensivist, but our primary role as an every intensivist is to actually take the ownership of the organ donation program. Well, unless we do the organ donation, our surgeons will not be able to save life. Our pulmonologists, our hepatologists will not be able to list their patients at all. So I think the young generation needs to basically understand that just as important as doing a morning ward round is your core responsibility, it is our core responsibility to identify brain dead patients, to do the testing, to declare the patient dead, and then ask for organs. If they say yes, that's fine. If they say no, that's fine. Don't be presumptive that they say yes or no. Your first duty is that just as if a patient dies, you do a ECG and patient declare the patient dead by either using a stethoscope, listening to the heart sound, lung sounds. Similarly, declare the patient brain dead and make sure that the patient's family is given an opportunity to at least say yes or no. Our problem right now is 99% of the times doctors don't give that opportunity to the patient. And you know it very well in our unit or in the units where you must have worked before as well. If you ask, at least they are compelled to think and they will then either say yes or no. But if you don't ask at all, then that's an opportunity not given to them at all. And of course, there are processes for that. In some unit, intensivists may choose to do it themselves. I am a strong proponent of that. But in some units, it would be the social worker or the donor coordinator. I'm a strong proponent of that process as well. Nothing wrong. Whatever works in your system, utilize it. There is no one size fits all process here. It is something which fits the local culture, the local dialect. If I have a Gujarati patient, I might want a Gujarati doctor or a translator person who could actually explain them well. If I am a Maharashtrian, I would do in Marathi probably well, because that connect has to be there. So I think that's where our young generation need to understand. It's just not about the glamorous role of being a transplant intensivist. Our role actually starts from organ donation itself. So it's very, very important.
So well, that's what I would like to pitch in, Dr. Bishwarup. So what is your how do you want to when you see a donor, in the unit, or you think he's a probable donor in the unit, what comes in your mind? Suppose from the beginning.
So that is how I thought I would moderate that. All the
Yeah,
questions
go ahead.
are very valid, but we'll probably run short of time in half an hour to answer all of them. The one way forward to increase the donor pool will probably be working on the Maastricht category 4 and category 5, the controlled DCDs, and as well in the controlled, disease brain dead donors, there has to be an active nucleus that identify. Rahul sir said it very nicely that we have to identify patients, because previous units that I have worked, there always used to be a term that there is a probable brain death, awaited brain death. So that thing has to be very active. You have to sniff those organs, talk to the family, prime them, and once and kind of keep managing them. There is a paper that I've put in my presentation. If you can see, I'll just share my screen, sir.
Dr. Sandeep, if you wish to have a donor, what would you would like to see in the donor patient, so that you look from angle that you want to have a best outcome of it, or you want to be little cautious that I'm taking such marginal donor, or I'm taking a donor which is healthy. Right from the beginning, what is in your mind that we should keep in the mind, and we should take care of things to have a healthy donor for the transplant?
Awesome. So I think this is fundamentally important. Other than identifying BSD, also looking at other alternatives to increase the donor pool. I think one of the most fundamentally important questions is we have limited donors opportunity. It is very important for us to maximize the yield from every single potential willing donor. And that means that if we can utilize both kidneys, the heart, lung, and the liver, probably the pancreas to go forward, maybe the hand and things like that. I think it's very important for us to optimize and manage this donor well. So, like Dr. Pandit said, and I would like him to elaborate, and probably even Ravi to elaborate on these, that as soon as the donor is identified, I think donor management is the key. And donor management is something that is a science by itself, but it can be learned and it can be taught. What is important is if we can adequately make sure that if we can make sure that the patient is covered for basic infections, if the airway is taken good care of, if the patient is monitored and managed with the judicious use of inotropes and fluid administration, fed reasonably well, I think you could possibly avoid the biggest danger for all transplant recipients, that is the transmission of donor-derived infections, whether it be the lung or the liver, kidney, or whatever it may be. This probably would allow us to utilize almost all available organs. One of the challenges that we see currently in most ICUs, that is nearly 90% of the ICUs across the country, when we have deceased organ donors, is the simple fact that they have tons of fluid administered simply to keep the donor hydrated, to prevent the kidney and the liver from getting damaged. The unfortunate downside of this, and the use of vasoconstrictors, noradrenaline and vasopressin in enormously large doses. They are not even controlled using a dosimeter or a infusion pump, syringe pump. They are usually in a drip form, and that is uncalculated. And I have seen young hearts getting wasted simply because of excessive use of vasoconstrictors and inotropes, tachycardia, dilated ventricles, poor ejection fraction. That heart from a 30-year-old donor is obviously non-usable. Likewise, positive fluid balances of over 10 to 12 liters would just choke the lungs out. That's the other problem. So if we do not have goal-directed donor management, then we will obviously continue to lose many precious organs from young donors, and unfortunately, our programs will never move forward.
Fantastic, sir. Fantastic. So basically, for lung transplant, fluid is a bit of cautious, and it is a red flag. All of us need to make sure that fluid management is one crux. If you want to procure, if you want to lead into this program, I think the fluid management is the key to donor management, apart from other organ system. Having said that, exactly a bit of different opinion comes when you want to optimize liver. So, Dr. Ravi, what do you think about fluids in the when is fluid you would like to hydrate the patient or you want to keep the perfusion pressure maintained? Which is more important, pressures or a fluids balance?
So we, of course, would like to keep the patient well hydrated, but not overhydrated. So there is no role for overhydration. And even I agree with Dr. Atawar that often patients, especially in smaller hospitals and some smaller towns, there is no limit on how much inotropic drugs they are going to use. So that is not good for the donor at all and not for organ preservation at all. One of the best practices I've seen recently on a trip to China is that they have dedicated nurses who take care of donors only. That's all they do. On a day that there is no donation, they do nothing. But then they're so specialized that they can literally keep the donor stable for days. And they when I arrived there, when I went there, they told me that we are going to do this, and I reached there on a Sunday. I asked them if there is a case tomorrow. They said no, and I said, I can come on a day or night, any case, anytime. They said no, we have a case on Tuesday. So I was shocked because they said Tuesday. So they said, oh, we have a routine OT days on Tuesday. So if the donor remains stable, then we all do it electively. So that is the power that they have with such a stable patient and a facility. The nursing and the intensivist are all dedicated to that. And therefore, they can do this, something that we can only imagine. So, what I envisage is if the government or NOTO or somebody takes initiative, we could even have one donor management team in each city who could go to the hospital where there is a donor and then manage them. And they're because they're independent of the hospital, it works actually beautifully. So that's what I think we should do. We have to have dedicated donor management teams.
Yeah. Dr. Bishwarup, quickly one or 2 minutes for donors, and then we'll switch to the next topic. Dr. Bishwarup, can you hear
Is
me?
my speech viewable now?
Yeah.
Yeah, sure. Thank you, sir. So basically, I thought that I'll put a DCD at the base of it. I mean, Ravi Mohankas has spoken enough about DCD, but there is an upcoming concept in the West, especially in Spain and other countries, about uncontrolled DCD. So where there is no concept of any brain dead or planned DCD. It's basically unsuccessful resuscitation in the ER or in the intensive care where patients are turned into donors. I understand there is a higher warm ischemic time, but recent studies have shown that DCD only programs also have similar outcomes, like uncontrolled donation after circulatory death only lung program. They have shown similar results comparable to other planned DCD programs from Maastricht category 4-5. So that is one thing to increase the donor pool. The other thing that I'll probably wanted to harp upon is there is an active paper this year, lung donor selection and management. It's by some intensivists from Bombay itself, along with other people's working from Kentucky, New York, Langone, and Texas Southern Western Medical University. So as said earlier, I mean there is no better way to have a dedicated donor team, donor nurse and donor intensivist, where there are plenty of things that the intensivist can do. And if you look at it, they are using non-invasive continuous cardiac output monitoring. They are maintaining optimum hemodynamics, not using noradrenaline more than 0.20 mics per kg body weight. And yes, it is not uncommon in India to go and see somebody having a bottle of NS with some noradrenaline to it at say 50 ml an hour. I mean, you don't know even what mics they are on. Uh, the other thing that can be critically important is at times to have a multi-organ donation. One strategy may work for one organ, the same may not work for other. Like for lung, we always want a restricted fluid balance patient who's kind of a bit dry. Whereas the same may be counterintuitive if the patient is having both a lung and a kidney harvested. Uh, the same may be true if you're giving, say, you're using a reasonably high ppm of 10 centimeter water and kind of recruiting the lung, which can improve the donor pool, but at the same time, this might go on to hurt the hemodynamics and result in not a successful heart harvest. So there has to be a dedicated team. And I would like to bring this slide. Just messing it up. There is this thing that is being used by the Cambridge University artificial intelligence team. It is called the organ IT and the organ sync, and there they will put all the organ parameters for a particular patient. It's in developmental stage, and I believe that organ sync cannot be used by physicians outside the NHS, but they can feed in all values, and then it goes on to scan their entire database of all the probable recipients across England and Scotland, and then kind of match them to this possible organ, and then kind of give you in detailed overview as to how you should hemodynamically manage the patient, how you should manage the patient for multi-organ harvest, who does this organ go to, and it is kind of a centralized system where individual state or regional organ transplant organizations do not get involved. It's kind of a nationally distributed thing. I understand we are a big country, but our organ transplant is not that big that we cannot implement a similar system and have organs allocated at the earliest, and then kind of manage them individually, kind of give them like an organ specific individual management to every organ, and kind of make them a
So,
very
yeah,
plausible.
if I may just jump in, Bishwa, the fundamental problem, and I think Dr. Pandit and Ravi might kind of allude to that.
Yeah.
Unfortunately, in India,
Yeah.
health is a state subject,
Yes.
and that brings in many interpretations as far as organ donation is concerned. So probably Dr. Pandit might be in the best position to tell us why do we have this challenge of not being able to get organs allocated to patients simply because of the allocation system and its pitfalls. Yeah, Rahul, please.
Yeah, I think it's a big problem, organ allocation, and we actually have organs which are getting wasted because we cannot go and pick them up from other parts of the country, and that's just the way it is functioning. And really don't think it's rocket science. So, Ketan, just dividing your question a little bit behind and then answering Dr. Attaw's question. It's not difficult to manage a donor. In the last 100, 150 odd donors that I must have done, I have not lost a single donor for hemodynamic instability. It just requires common ICU practices to be implemented properly. Early identification by the intensivist in conjunction with the transplant team at which organ is likely to be utilized. If the liver is not going to be utilized, I would keep the lung as dry as possible. If the kidney is not going to be utilized, keep dry as possible. Why would I bother about liver and kidney if the lung is the only organ which is going to be retrieved? In a multi-organ retrieval system, you have to balance it out. You have to keep euvolemia as well as sometimes a little bit of less volume. Less volume is fine, but too much of volume obviously causes a little bit of a problem. So it's not very difficult. Coming to Dr. Attaw's question, I think it's just that states don't talk to each other. That's the problem. And NATO, which is the organization which was supposed to bridge that gap, I think in some stages it actually has increased and divided the gap further rather than bridging it across. I am sorry to be very blunt and honest, but if you call up Maharashtra today, Mumbai, let's say we have a donor today, first call goes to ZTCC, then the ZTCC will do the distribution for Mumbai. Once they ran out of options in Mumbai, they will give an alert to the ZTCC of other four cities, three cities. Then it goes to the region, which is Roto. Then it goes to goes to the national, which is Noto. Now, let's say Dr. Attawar has got a patient in Delhi who is registered there, who could utilize this organ. Dr. Attawar can fly from Hyderabad to Delhi in 2 hours, but the organ will not reach there even in 20 hours. That's the big problem. And I just don't know how to sort of bridge that gap, because everybody knows that this patient could be given this organ, but the whole process takes such a time that by the time the retrieval of that patient is the organ is happening, Dr. Attawar is given only 1 hour to make his presence felt immediately there. कि आप आके organ लेके जाओ तो ही होएगा, या Dr. Mohanka has to just rush there and do it, which practically is not possible. And organ donation here is not a state sponsored process. So charter flights or special flights or even out of the hour flights do cost a lot. You take up a flight early in the morning, it might be a full Bombay to Delhi flight, 20,000 rupees ticket, and you're paying it. It all adds on to the cost of the transplant.
Yes.
So I think we need to be a little bit more transparent and easy to do that. It's not very difficult. It's not rocket science. Noto needs to take control over it.
Absolutely.
as geographicically we have so many issues, India being such a big country, and sometimes the organ is at Jammu Kashmir and the recipient is at in the southern part of the country.
That is
Now,
the next
in
point
that
I was trying
in
to
the,
harp is that if not DCT, then the other option that we have is machine perfusion, where we can either introduce a subnormothermic, normothermic, or a cold, like a hypothermic machine perfusion, so that you have a larger longevity of the organ rather than the static cold system where you can store in heart for about 4 hours and lung for about 6 to 8 hours. So utilizing this system, so we might be able to create a system where we can have these organs outside the body for a longer time. And there have been some inexpensive methodologies that have been introduced that have resulted at least in lungs being viable outside the body for a median of about 12 to 14 hours. So that's another thing.
What is
so
inexpensive, Dr. Biswaru?
So the inexpensive method is it's a company
What
called
is the cost?
Paragonics.
I'm asking you,
Yeah.
what according to you could be inexpensive cost?
Inexpensive is something less than 10,000 US dollars per transplant.
Yeah, so
Which
that's
is
8 lakh rupees.
Yeah, which is a
So the
scalable
whole
number.
problem is that you put 5 inexpensive therapies and we could transplant a patient with lung and heart both together in that five inexpensive therapies.
But the Paragonic system is one which comes at a sub 10,000 US dollar cost, and it's a reusable system. So with
Okay.
our
Good.
expert,
Anything
with our,
reusable is good, but are we allowed to reuse officially, or is it
with our world leading expertise on ETO, I'm sure we will find a million use to use them beyond their usual shelf life. Paragonix lung guard is something which results in a lung being viable for about 10 to 12 hours outside the body, which basically uses the Toronto 10 degree protocol. They have further introduced something which was recent in Toronto, as recent as 2021, when they worked on inflating the lung with a little bit of a CPAP, and that's introduced in the US as the Paragonix lung guard. I believe the first few inpatient trials have completed at the end of 2023, where they've done about 6 or 7 cases in New York Presbyterian and Temple. They've transplanted about 4 or 5 lungs in between those two centers using the Paragonix lung guard. They cost in the range of some 7 to 8,000 US dollars to buy the system. They're basically fridges with a good temperature control and a thermostat, uh, with some integrated technology where you can kind of monitor the live, track the organ and other stuff. And it has got no big consumable part that it needs to be changed every time. Just a simple ET or a simple uh, sterilization, and it's good to go. So that is one
So
thing.
I'll just jump in for a
Yes, sir.
second here. One of the fundamental problems in India is that most donations that we have on the lung and the heart side, and I'm sure we must ask Dr. Ravi Monka for his opinion on on the liver side. Most hearts and lungs are marginal organs in this country, and I mean marginal organs. They are suboptimal, and the current paradigm of preserving all of these organs is static cold storage. The problem with static cold storage again being is there is no way to monitor the organ once it is arrested and put it in the ice box. The quality of the organ degrades with time. Sadly, these organs being marginal cannot be improved upon, whichever the paradigm as far as storage is concerned. And unfortunately, it is a given rule or a thumb rule in transplantation that when you take a marginal organ and use it for a marginal recipient, the outcome is going to be less than marginal. Most of these patients will not do well. Our fundamental problem and the reason that we do not have a growth in the field of thoracic organ transplantation in this country is simply because almost all our organs are marginal and the efficiencies are so bad of organ allocation and transport across the country that most units do not have access to these organs. They do not have the ability to cut down ischemic time, to keep it to the bare minimum possible, because that comes only with experience. And that is probably one of the major roadblocks for the growth of thoracic organ transplantation in this country. And not to mention that most patients who accept that they will undergo a heart or a lung transplant are usually ones that are close to death. The ones who are very, very sick, who are hospital bound, who probably are on large amounts of oxygen or are on a ventilator are the patients who finally agree for a life-saving transplant. These are not good patients to begin with. And if you use a marginal organ, your results will be suboptimal. So there are many challenges in the field of thoracic organ transplantation. I would like to hear some from Dr. Ravi because I think we haven't asked him a question in the last 10 minutes. Yeah, Ravi bhai.
Yeah, so one of the, I agree with you, although for liver at least it has changed over time. So in the
Ji.
past, we used to get even from a very standard 40-year-old donors, we used to get very marginal organs. Things are getting better in the last 5 years or so. I would say that we are getting better organs now, and at least from standard donors, unless they are from very small towns. But from within the cities, we are getting decent quality organs. But again, there will be smaller hospitals who will not know how to manage their donors, or there are increasing number of old elder donors now, for which is not such a big problem. If they're well preserved, then the organs really work well. So I think where heart and lung organ donation is right now, we were about 10 years ago with the liver, and but things have improved for us.
Ethan,
So
your time is almost
thank
running
you,
out. So let's
yeah,
concentrate on
yeah.
one or
So
two
we will
very
go to the
important things.
last question, which I would start with Dr. Pandit. If you want to see a future ICU, a dedicated transplant intensive care, what are the few things you would like to have? Just first top three things you would like to have if
I
you want
think
to have a solid organ transplant unit.
yeah, I think Ketan, we need to subdivide that into a heart and lung unit and a liver unit and liver and kidney unit. I think that's the bare minimum. If you don't, if not four different ICUs, it should be two different ICUs. One looking after heart and lung and one looking after liver and kidney. That's the bare minimum. You should have a dedicated team of nurses, and you should have a dedicated team of doctors, intensivists, and physicians working there. Um, and that will bring the volumes and that will bring the expertise also. Why do some centers in the world give us an opinion which is so solid, and we, having the same knowledge, are not able to give an opinion that solid? Is because we do not have a dedicated unit which does say, Dr. Sandeep has done 500, Dr. Mohanka has done 1500. Whereas ICU, I can give a general ICU opinion very firmly. Lungs, they can give an opinion very firmly. But one unit cannot give it because we have a process where multiple different places we have worked and gathered this information. Whereas, let's say Mayo or Stanford or somewhere, they have just one unit which becomes specialized and is able to give that process out, is able to have that expertise there. And that's what we need to develop. We need to develop a center of excellence. Is
So
it
Ravi, last
possible
two
in India?
points.
Sorry,
Oh, yeah, continue, sir.
is it
Dr.
possible
Ravi,
in
I
India?
was
I think it's difficult to say that because India is such a diverse country. It requires a little bit of innovation, and I admire the innovation of Dr. Attawar, that he's actually going to different places so that people who don't have access to his expertise are getting that. It is very difficult to get the patient to us so that we are expert. We will do it. I think the other model which Dr. Sandeep has needs to be emulated, which Dr. Ravi also does. He goes to various places and puts the transplant, does transplants. I think that's what we need to do. We need to start doing intensive care in the same way. So I think we need to start establishing small units where they will come. We will be able to help them out, and we will be able to have several centers of excellence, which sort of relates to a spoke and hub model with one hub in the center. That's how we should do it.
Hmm.
Dr. Ravi, you want to say something? Last few
Yeah, so
words.
I think that one of the key differences between the West and India is that infections that we get in India are really bad and almost very often fatal. And therefore, it is imperative for us to only focus on separating patients who are infected and not infected. So the my dream is a ICU where you can have three different parts. One is a group of infected patients, one is a group of non-infected patients, and one is a group of unsure patients. So a patient who comes from another hospital, you can put them in the unsure patient group until they go into one of the other ICUs. But these all three have to be physically separate from each other, because we don't lose patients to technical problems as many as we lose to infections. So therefore, I would my dream is that there should be three ICUs and they should be separated based on the infection risk and presence of infection.
So that's the most important thing. And Dr. Sandeep,
Yeah, if you ask me, I think one of the biggest challenges that faces transplantation in these early days is the fact that we do not have standard operating protocols. And when I mean that, I mean that for any patient who's transplanted, I think there are a set of rules that are unviolable. They have to be followed. And unfortunately, they still continue to be subject to the whims and fancies many a times of surgeons, or probably biases, deep-seated biases by intensivists or probably even pulmonologists or cardiologists. I think there is no space for that, because in our country, unfortunately, it continues to be the fact that if I have done more, my experience is considered to be overwhelming compared to everyone else, and my opinion is taken as it is written in stone. And I think that is unfortunate. I think it's very important that if we need to encourage and pass on this knowledge to the younger generation, we cannot expect them to spend 20 years in the field and then become exactly what we would not want them to be. I think we have to develop policies that will be followed, and there are standard steps that can be taken, and this will lead to better outcomes. That's one. And the second, I believe strongly, is the fact that we do not have transplant hematologists, nephrologists, hepatologists, cardiologists, pulmonologists form one core group, which basically allows each one of them to have exchange of information. A patient who comes for a lung transplant does not have a challenge with his lungs alone. Because of chronic lung disease, they have systemic challenges with many other organs. And these are issues that cannot be addressed by a cardiac surgeon or an intensivist or probably a pulmonologist or cardiologist alone. They need help. I think the fundamental difference that the West and we have is they have a policy on how these things work and how they problem solve. So I think that is very important. The last one obviously will be the fact that we still have many outsourced centers that kind of are available for immunological testing. We do not, most of our hospitals do not have that in-house, and that leads to a significant lag period, especially in the field that I work in, where information is crucial, information is gold. And if that information is denied or delayed, I think it can automatically lead to a bad outcome. So these are probably things on my wish list.
thank you so much. And Dr. Bishwarup, just quick one, because other
I
panelists
think
have joined
things,
for the
things
next
to
session.
summarize point wise would probably be DCD, machine perfusion, better allocation, a trained intensive care team, and a multidisciplinary approach where we have a fixed pathway that somebody having something wrong with their peripheral blood smear post transplant, we know whom to call. I mean, it's not like we call Attawar sir and then sir goes searching around the world for the best person. So, I mean, it has to be a very fixed protocol. Something going wrong with his blood smears, we call him. Something going wrong with his cardiac function, we call X. With his lung function, we call Y. So, everywhere they have a written down care of the adult lung transplant patient. Like Auckland had a written one, Vienna has a written one. Canada is a very big size country. They have a written one in Toronto General. So they know whom to go to. So we need to have more cohesion. And yeah, these are the five takeaway things. So DCD, machine perfusion, better allocation, multidisciplinary approach, and a better presentation of the patient to the roto, soto, whoever. Matlab, like, not like a brain dead patient just presented. Like, have a brain dead patient. That's your cake.
Thank you. That's wonderful. Thank you, everyone. Thank you, Dr. Sandeep. I'm sure you're traveling and your hectic day. Dr. Ravi,
Thank you.
it was fantastic session from you, and Dr. Pandit always supporting us. And Bishwarup, thank you, Dr.
Thank
Bishwarup.
you.
You have made an excellent presentation. I will hand over the session to Dr. Pritima for the next panelist who are just joined here. I can see Dr. Lakadwala is there, Dr. Santoshi is there. Welcome, and Dr. Paresh is there.
Thank you very much, Ketan. Thank you, Ravi Bhai, Sandeep
Thank you.
Bhai,
Thank you.
Vishwarup Bhai, and Ketan. Thank you very much.
Thank you.
All of you take care. Bye bye.